right. Thank you. Yeah, it's an honor to be with you all during this time. I think when we think about us as counselors and working with clients, of course, trauma definitely takes up quite a bit of room in the session. And as we've progressed just in the field and understanding what's behind so many different mental health symptoms, and especially interpersonal issues, I think more and more the attention is appropriately being put on just the impact of trauma as well. And yet, probably in our endeavor to address, trauma and all the symptoms that go along with it, we've probably experienced some barriers to any kind of success. So I definitely wanted to provide a webinar where we're addressing some of those barriers and really put it in the context of how relationships have quite a few implications in trauma reprocessing. So objective-wise, just kind of broad overview here. We're going to go over attachment orientations, or we could also say attachment styles. Um, and its importance in psychological development and trauma. And then taking that and looking at how really attachment orientations can create implications for reprocessing and the recovery from traumatic experiences. And then finally, give you some tangible interventions to facilitate and at least just kind of think through from a case conceptualization standpoint. You all probably have other interventions that you like to integrate in trauma reprocessing, but I definitely wanted to highlight a few that have a more interpersonal and attachment related emphasis in that work. So, all right. Well, in discussion, like I said, I think most of us are probably here because we have facilitated um, various treatments where we're addressing PTSD. And in that, like I said, sometimes there are some challenges there, and we probably can relate to some of these that I'm pointing out right now, where in general, when people are coming to therapy to address trauma, these adverse experiences that they've had in life, there can be a high attrition rate. They come to therapy to get some support. A lot of times, um, it's not just they have these symptoms in their lives, but these symptoms are now impacting various areas of their life. Relationships are being affected, how they can show up at work and social settings, if they're in college, sleep, appetite, so many areas of life start getting just touched and also impaired by these unaddressed events in their lives that have had these lasting impacts. And so, there are different kind of routes people get to, and go through when it comes to therapy, but a lot of times when our lives are being impaired by certain issues, it tends to be a big motivating force. And I'll quote Dr. William Glasser, he's the founder of choice theory and which also created reality therapy. From his perspective, people are most motivated by relationships. When people experience impairment in relationships, a lot of times that's what people need to say, hey, you know what? I need to do something here. I need to address this. And so on my end, I can say that's especially true. I've seen most people be motivated by impairment in life to come to therapy. But then there are challenges, even when they do come and try to get help. And so there's been research, even recent research, this is from 2021, of saying while people might come to therapy to address trauma, it can be hard to get people to stick with it, to do the work that they need to do for the amount of sessions needed. And so discontinuation of treatment is a real possibility. And that's also especially true when people come to therapy to address trauma and true when the treatment itself or the therapy itself is keeping the trauma, the event at the forefront. And we'll talk about that later as well. Now, some other research that's been kind of published is that perceived low social support is actually linked to the type of response people have in trauma-focused therapy. So this is looking at, outside of therapy, do I perceive that I have people outside of the session, people after the session, to be able to support me in what I'm going through in life? And I think it's very pertinent to recognize when people feel like they don't have that necessary support outside of session, it can negatively impact the success of the treatment, the outcomes overall, how much kind of PTSD symptoms are reduced, and then even a discontinuation, like a premature discontinuation of trauma-focused therapy. So bringing that to the forefront, I think it's just adding to the need to emphasize relationships matter, especially outside of the counseling session, and especially when we're trying to address trauma. Okay? Now, connecting this with attachment theory, perception of social support. So it doesn't mean that it's not there, but do I feel like I can access them? Do I feel like I'm a burden to them? Do I have willingness and even the skill set to be able to discuss what's going on within me to know how to get support? And so a perception of social support is actually postulated to be a byproduct of attachment related concepts. So we'll integrate that in just a moment. And then I also want to point out Shapiro's work, founder of EMDR, and helping to also bring to the forefront that, our relationships, our perception of support, things like that, can be significant predictors of whether people end up with a diagnosis of PTSD and even just the symptom severity of PTSD. And so while there can be relationship factors that predict those matters, sometimes the thinking can be that, if I just address the trauma, if I'm facilitating these PTSD treatments such as EMDR, brain spotting, those matters, that it will actually create some positive effect in a person's relationship. Unfortunately, that's typically not true, based off the research. So it's possible that it lends itself to that, but from a research standpoint, just because you're having success with PTSD symptom severity reduction, I know it's a mouthful, but just because the symptoms are reducing in severity does not mean people are going to suddenly start engaging with people in a more, efficient and helpful way. And so to me, it's two different types of work that need to be integrated, and that's setting the scene for what we're going to be talking about today. So when we think about PTSD treatment, let's look at the research in general, but also the VA is really behind a lot of, what treatments are the most effective when it comes to reducing symptom severity. So the psychological treatments with the strongest recommendations from both the VA and the International Society of Traumatic Stress Studies include these three. And these are not the only ones, but these are the ones at the very top in terms of reducing that symptom severity. So, first and foremost, prolonged exposure. And I'm not going to go in depth with all of these. I'm going to talk about what they have in common in just a moment. But prolonged exposure is used very commonly, especially those in the military. In addition to that, there's cognitive processing therapy, which has an even stronger cognitive, core beliefs component to the work. And then, of course, we have what I think is very well known out of all three of these, eye movement desensitization reprocessing, or EMDR. So these are the modalities that are endorsed the most and the highest, in a sense, when you think about what is kind of stood, I want to say the test of time, but really kind of over just the past few decades, where trauma therapy has really kind of become much more well known and well facilitated, at least in the country, if not the world. But with all of these, there are some commonalities. So the common elements of those three PTSD treatments that I just mentioned include these three matters right here. For one, addressing experiential avoidance. I'll read them and I'll go back and elaborate. Activation and engagement of the traumatic memory, and then addressing trauma-related cognitions. So we'll go over the PTSD symptoms in just a moment, but I think we all probably recognize that avoidance can really perpetuate the symptoms that go along with PTSD. Anytime we've had an event in life where it's brought about so much distress, our brains are really just doing um, what they know to do to keep us alive, which is to avoid that thing that hurt me so much. The issue sometimes is that that avoidance really prevents me from having what can be referred to as disconfirmatory experiences, or a more attachment way to phrase that, corrective emotional experiences. And because of that, a lot of times my brain is overgeneralizing the threat, right? So I might have had an event where one person engaged in some type of abuse towards me. My brain can overgeneralize and say all people of that sex or gender, or all people in general, are now dangerous. And so then that's going to have implications on how I engage with other people. And if I'm not engaging with other people, then I'm not, once again, allowing for a disconfirmatory experience or a corrective emotional experience, meaning I'm probably going to now start isolating. And if I'm isolating, that means I'm not receiving the support that I need. And so these treatments have a person really um, it encourages them and prompts them more from a visual perspective to engage. And that's the second bullet, to engage with the traumatic memory that a lot of times there's an attempt to avoid. And then, like I said, in real life, avoid things that remind them of that past experience. And then the other common element with these PTSD treatments includes addressing trauma-related cognitions. There's so much research that shows that the meaning that we made of what we went through, it's not just what I went through. The meaning made is such a predictor of the amount of distress that I experience following that event. Okay? So those three factors right there become the focal point of the treatment. And looking at this last line that I have, I'll keep the traumatic event or maybe multiple events at the forefront of treatment. So maybe we facilitated these therapies or been a recipient ourselves as clients, but when we've gone through a very difficult situation, the idea of going into a session, even when I have trust with the clinician, the therapist, the idea of putting myself through sometimes 50 minutes or 90 minutes of distress, you know, no wonder sometimes people drop out. And so once again, I'm a fan of this. I facilitate this, but it does need to be considered of what the experience is like for the person. And for some people, they're just not at a place uh, or willingness to re-engage, even if it's, quote unquote, just a memory, but they're not willing to engage with it due to the distress that it's historically brought to them. And so, from that place of compassion, it's very important to think about, what are some alternatives? What can we do when the idea of the way in which to get somebody help is provoking even more distress? And I've said this in a past webinar, but I remember a couple years ago, I had a client myself who, when she wanted to address her PTSD diagnosis and the symptoms that were going along with it, especially avoidance, because that avoidance was truly impairing her life in such a way where she wouldn't even want to leave her apartment. That's the level of avoidance that she'd gotten to. When I talked to her about PTSD treatments and these gold standard approaches like prolonged exposure, cognitive processing therapy, EMDR, just very tearfully, she asked me, do I really have to relive that moment? Even in here with you and knowing it's more of just a recall, she's like, is there no other way? And so that is what got my attention of realizing, hey, before I just jump into even these gold standard approaches that do have research behind them that suggest, hey, per the research and statistically, you will have symptom reduction, statistically speaking, you will. Um, I might need to consider other things or put some supports in place before we engage in that work, right? No, just to make sure everybody's on the same page, I think we all can recognize trauma in its various forms, but when we're really looking at it from a criteria standpoint, categorically or symptom cluster wise, this is what we're looking at. So, as a part of a PTSD diagnosis, intrusion symptoms or re-experiencing symptoms are quite common. That includes both flashbacks, of course, when we're going about our day, um, and then including nightmares as well. So disturbances in sleep. Is even getting impaired due to the unprocessed trauma. And then the second one is avoidance. We've talked about that one, but how a lot of times, anytime a person has avoidance in their lives, um, due to the inability to have a corrective emotional experience, that avoidance a lot of times perpetuates so many of the other symptoms because it's hard to address it when we're avoiding it, right? And then the negative alterations in mood and cognition. So, typically speaking, when we go through something adverse, it's negatively impacting our general mood, like how we're feeling. So, it's very common that more depressive symptoms emerge, more anxiety emerges as well. And then cognitions, like the way we're thinking. And when you think about cognitions, you're thinking about in certain categories. So we're thinking about, you know, after I went through this event, what did I start believing about myself? What did I start believing about other people? What did I start believing about the world that I live in? And then the fourth one that's often viewed is, what do I believe about my future? So when we're listening to clients without even sometimes having to ask them um, about negative core beliefs or cognitions, we can a lot of times really hear that, you know, we can hear the way that they believe about themselves in certain contexts, especially what they believe about other people. And again, that really sets the scene for how they're going to go about life because so many of us, our actions are significantly influenced by our belief system as well. Okay. And then we also have alterations in arousal and reactivity. So when we think about arousal, we can think about the autonomic nervous system, and that's where polyvagal theory has been so helpful in conceptualizing a sympathetic state and a parasympathetic state as well. And so including that those reactivity responses that we have, or adaptive responses, as I believe Dr. Porges and Deb Dana have pointed out, of sometimes this fight, flight, freeze response or responses that comes out of it in an effort to keep us safe, right? So as we go through this, just recognizing these symptoms are oftentimes um, what's setting the scene for this impairment in a person's life, which is then kind of prompting people to come get help. From a more interpersonal standpoint, when it comes to trauma, these three symptoms are often a part of it as well. Now, I could categorize these in the other four, but again, making this focus not just about criteria, but putting this in an interpersonal context. One of the horrors of, going through a trauma is our survival mechanisms a lot of times kick in. And while that's helpful in the moment, the idea that that's the way I deal with things moving forward obviously creates a lot of impact and impairment. So, affective detachment. So, sometimes when we go through difficult things, the way in which we deal with the distress is that we learn to disconnect ourselves from our body, from our feelings. What I always tell folks in those moments of them talking about basically their coping mechanism, because that's what this would be, is that you did what you had to do back then, but the idea of continuing to do that means you'll probably be lacking in intimacy with yourself. It's really hard to ever really get to know yourself if you're so disconnected. And the other piece of that is that you know, it's not that we're actually not being impacted by our present environment. We've actually just learned to cut off our awareness of how impacted we are by our environment. And then that impact a lot of times comes out in these various behaviors that we have. And so I work with a population who's typically dealing with addiction, and I very much see addiction as a result of affective detachment. Like I don't want to feel this the way the environment's affecting me. I don't want to feel this. I'm going to push it down, suppress it. But then due to this known dysregulation that our brain is picking up on, then we engage in these behaviors that, numb us out a lot of times or induce us with a ton of dopamine as well. So part of trauma is actually helping people get back in touch with their emotions and making it a safe experience to go inward. The second one is a mistrust in the environment. I mean, no doubt, them being in a certain environment, this certain very difficult experience happened, And so it's hard to just kind of let our guard down. And then the third one is, especially in the context of relationships, we're on hyper alert. A lot of times, trauma is done by the hands of another person. Like we've been let down in a very significantly harmful way, um, if not abused to a certain degree. And so, if my woundings are the result of other people and relationships, then no doubt my brain is going to go on hyper alert on can I trust people? And a lot of times there's a mistrust moving forward, which means I might not get the level of support that I need in that moment, which then sets the scene for I'm going without consistently. And this is what Shapiro is referring to in that I've had something where a wounding has happened. It set the scene for how I experience future people. And because of that, I'm no longer feeling safe to engage with people in the way that I need. No. Let's put this in the context of attachment theory as well, because we're setting the scene here for relationships, but let's kind of go to the foundations here of what attachment theory is all about. So, attachment theory has been around now for many decades. It's evolved like many theories over time, but it's especially important when we're thinking about trauma reprocessing, especially if you think back to that interpersonal context that we just talked about. So Dr. John Bowlby, being a British psychologist, set the founding work when he looked at the impact of separation from a mother after World War II, looking at what he referred to as juvenile delinquents as well. I do recognize some of his work is controversial and might feel like it has too much emphasis on the mother and not really recognizing the role of the father, or other caregivers that might be a part of a person's life. So I recognize that, and I know over the decades people have really, in a sense, verified the importance of, let me just say, a child and caregiver relationship, which I think is more appropriate nowadays to say. But based off John Bowlby's work, then we have Mary Ainsworth, who really helped so much to be able to create a classification system for various attachment styles. So if we were to combine their work, really what's underneath attachment theory is this postulation that we as human beings are biologically wired. We have this instinctual drive when we experience distress to seek out close relationships for the purpose of establishing safety and security within us. And so nobody has to be taught that. And that's part of the point that Dr. Bowlby was making, in that no one has to teach a child, hey, come towards me when you're upset. We see these various behaviors like crying or throwing a tantrum. And, sometimes people have very negative interpretations of those behaviors, but really what's, theoretically behind those behaviors from an attachment standpoint, is it a need for connection in those moments? And so going back to the point, just like some mammals that we see, they don't need to be taught those behaviors. There's this instinctual drive that we're born with. And I use the kind of corny metaphor here of like a sea turtle. No, the mother sea turtle does not have to teach her children, in a sense, hey, do you see that water right there? Go towards it to be safe. They just know, they're just drawn towards it. And so taking from that the aspects of, how we can relate to the animal kingdom, in a sense, we're wired to, when we experience distress, we want somebody, right? We're born like that, and that never really goes away, but definitely can be impacted by trauma. Yeah. Now, even though we have that drive to go towards a person, um, based off the experiences that we have when we get to them, to that caregiver or to that adult, really then forms what can be referred to as internal working models. And so we think about those in two different ways. What do I believe about myself, and what do I believe about other people? Think back to the PTSD symptoms, alterations in cognitions and mood, alterations in cognitions. What do I believe about myself? What do I believe about other people? That then has a strong influence on what I end up doing when I'm in distress. Right? So we'll come back to that concept in just a moment. But the quote down here at the bottom from Bowlby is that from his conceptualization, our attachment style, whichever one we would find ourselves in, um, that attachment style or orientation actually goes across our lifespan. So whatever's formed in childhood from an attachment standpoint, we will carry those internal working models which influence our behaviors when we're in distress. Those behaviors will relatively stay pretty consistent um, all the way to our death, right? Now, I don't have this quoted here in this PowerPoint, but there's been quite a bit of research that actually shows, therapy very much does influence attachment styles. Even 12-step meetings have been shown to positively impact attachment styles. So this is not a doom and gloom statement, as is, intervention can happen. But our early life experiences really do have such an impact on us, especially in the context of us in relationship all throughout our lives. Yeah. Now, really just trying to illustrate um, kind of what happens, this process, this instinctual drive. So, us being born, when we experience any kind of threat, and I just, used a lightning icon to illustrate some distress or threat in the environment. Um, Anytime we experience that, there's this activation of the attachment system, this need for, hey, I want someone in close proximity. And so, the primary coping skill, especially for babies, for toddlers, and really from an attachment theory standpoint, it's the way we always want to cope, in a sense, with distress, which is to have somebody, for somebody to come towards us or um, we go to them, but just to experience connection. And in those moments of connection, in an ideal world, an ideal situation, when we experience that close proximity, we experience attunement. And that attunement, that I see you in a sense, that I'm with you. I'm not trying to problem solve and take it away. I'm with you in this moment, leads to co-regulation in a sense. So the way in which I'm learning to be okay, to feel secure, is actually through connection, through I'm in distress, I go towards a person, and my felt experience is that, you know what, this is really helpful. That when I'm in that distress, to just be with somebody, um, it lends itself to, hey, I'm gonna do this in the future, right? Now, sometimes people think that sounds like codependency, but um, it's very healthy to want to connect with somebody in those moments. What can make this healthy, in a sense, is that we learn when we've had pretty consistent attunement throughout our childhood, even if we're not around somebody or don't have access to somebody in the moment, we can actually use what's referred to as internal models. We can actually reference the past where somebody really was with us, and we can even recall their words and the way in which they comforted us to engage in self-regulation. But the point that I want to make with that is that all regulation is actually rooted in co-regulation. Anytime we're even doing something for ourselves, like deep breathing, I would say we learn to do that deep breathing through some type of interaction or engagement. Some people might say, well, no, I actually read it off a website, but I would say, who wrote it? Somebody wrote that, a blog about how to use deep breathing. And so to me, even in a sense, that can be co-regulation. Um, but we learn throughout life, like, hey, the way in which I can establish some security comes through interaction and engagement with other people. Now, things can go awry though, and we don't always experience the very thing that we want and need in a given moment. So it doesn't change that we want somebody, right? We experience a threat, our attachment system is activated, we seek proximity, but let's say we don't get it. So let's go to number one. And so what can happen is even though I want connection, nobody's really there. And this can go a lot of different ways. So I'm just kind of giving a couple examples here. Um, but let's say nobody's there. Nobody was able to comfort me, or I was even directed to go away, to leave them. And so because of that, I start to develop these once again, core beliefs of myself and of other people. And we'll talk about those core beliefs in just a moment, but secondary coping strategies end up being developed. So when I've consistently had the experience of nobody's there, nobody's here to help, I got to do this all by myself, people engage in what are referred to as deactivating strategies. And this is very characteristic of avoidant attachment styles, where yes, I do experience emotions in my body in the beginning, but I overdevelop this ability to suppress, push it down, cut it off, and not become aware of it. And so the longer I really kind of use that muscle that all of our brains have, in a sense, the more I can become so disembodied or disconnected um, between how the environment's affecting me and my awareness of it so that I can actually go towards people, which is what I want. So there's deactivating strategies, which is more avoidance. The alternative here, number two, is what's referred to as hyperactivating strategies. So maybe somebody is there. Now I'll say this, maybe somebody's always there as well. And someone always being there actually prevents me from ever utilizing my internal models to access support, meaning I really never get the opportunity for some self-regulation, right? The other thing that can happen here is that in the presence of a person, I just start relying on them all the time in that moment. So my lived experiences is that I need someone to make me feel better. Like I've never really learned how to do it by myself, but it can be really hard to get people to always come towards me in a sense. And so the hyperactivating strategy here is that I actually end up elevating my issues. I escalate the intensity of what I'm feeling. Um, and I've learned, my lived experiences are that when I really elevate what I'm going through, um, people start coming towards me more. People are more willing to help because they're so concerned. So the way in which I get proximity or support is to escalate my issues, which means I probably commonly feel really bad, like all the time. Whereas a deactivating strategy is I cut off the awareness of my feelings. Hyperactivating is where I kind of escalate what I'm feeling. And both of these are very kind of unconscious mechanisms. We oftentimes don't even realize what we're doing. And so getting to the how do we integrate this, a lot of times there's some important psychoeducation with clients of helping them to know how do they typically respond to their own distress. And you get some clients who are very impressed with their ability to not feel anything. And sometimes you kind of really have to say, that's not something to be impressed about. Like we're hardwired to be, you know, affected by our environment, which then makes us kind of want somebody in that moment. So there can be these different strategies that I find to be very helpful to teach clients about, help them to recognize how they're using any and both of these as well. Okay. So when we think about these different strategies, that's when we can kind of see different attachment styles start to emerge. Now, these are based off core beliefs, right? And so reiterating some of what I said, when a person has an attachment-related anxiety, which is on this kind of x-axis here, if we were to look at this this chart or this plot right here, which unfortunately requires, if you think back to algebra class, an x and y axis, because you have two different scores. You have how much attachment-related anxiety in relationships, and then the y-axis is avoidance, how much attachment-related avoidance. These are actually two different scores if you were to ever utilize assessments such as the Experiences in Close Relationship Scale by Dr. Chris Fraley. Um, but you take those two scores and you plot it on an X and Y axis. And so I remember kind of laughing to myself of like, oh my gosh, like that actually was a helpful lesson in algebra class. So characteristically, low attachment-related anxiety and low attachment-related avoidance um, means that there's a secure attachment, meaning there's healthy engagement in relationship, felt security in relationship, and the ability to experience co-regulation, but also self-regulation as well, right? But when a person has high anxiety, a lot of times we see hyperactivating strategies develop. And that's suggesting that they have this low confidence in their ability to work through things and this kind of inflated confidence in other people as well. Whereas avoidance, kind of on the flip side, people get this inflated confidence to be able to deal with anything and everything because they're not recognizing how much they're impacted by the environment. And they overall sometimes have this kind of low confidence in other people. Like their lived experiences are that people are not helpful or people are just not there. And so therefore I got to depend upon myself. So I think it's very important that people realize and go back to their childhood and realize when I was in distress, when I needed support, what were my lived experiences? And whatever they were, because we're such meaning makers, we're like, what does this mean about me? What does this mean about other people? In the context of how to get through hard things. That sets the scene for how we deal with tough things in the future, which you see kind of what we're getting at. How we're going to utilize support moving forward when we go through adversity. So this is really showing how all this plays out. And I know we could probably spend an hour just on this chart, but just realizing that the first part, the first row is symbolizing interactions with other people, our lived experiences with others, and how those experiences either create or reinforce what we believe about ourselves and other people. We see the columns right here are the time orientation. So main point right here is if our past lived experiences are that people are going to let us down, a lot of times it forms these kind of inflated or negative mental representations or internal working models about ourselves and about other people. And we live from our belief system. So we get to the present day, we go through a difficult situation, and these maladaptive patterns emerge of deactivation or hyperactivation. And a lot of times it creates a pretty negative impact on the relationship. And because of that, it a lot of times reinforces our belief system about ourselves and other people. And that cycle just continues on and on and on and on. Um, this can go different ways based off if you're utilizing deactivating and or hyperactivating. But the main point here is that my early lived experiences are, I kind of want to say, not just influencing, but dominating how I'm showing up in present day relationships. Okay. So when I think about PTSD treatment, I'm thinking in these two areas. I'm thinking about regardless of what the trauma was, but a lot of times that trauma is interpersonally related. I'm thinking about what have been their past experiences when they went through adversity, because I know that's probably going to set the scene for how they're either pursuing support, right, in the present day, and then I'm also thinking about kind of from more of a CBT perspective, what are their core beliefs of self and of other people, right? So sometimes that can be two different sessions, like two different kind of topics in a session. I've even had a situation where I had a client where I mainly did the interpersonal work of encouraging healthier, assertive communication, seeking out support from peers, and then the guy had another therapist who only did EMDR work. That was just kind of a match made in heaven right there of like we as therapists were very targeted in different areas of the person's life. But I know not everybody can have that situation due to either time resources or even financial resources. But both of these lend themselves to each other. And this chart is very similar to the other one, except for 3B means the way I'm showing up present day, I've learned healthier ways to show up. I'm not engaging in avoidance with the person. I'm letting people support me, and it's working out pretty well. And because I'm actually getting very ideal support from a person, it's lending itself to more positive and adaptive mental representations of self and of other people, which is setting the scene for in the future when I experience adversity. Now I know people actually can be helpful. And or if people are not available right away, I can use some self-regulation techniques until people are available, right? So I always think in these two categories, and this is kind of my two-pronged approach to PTSD treatment. I'm thinking about how are they actually showing up in relationships, and then I'm also thinking about how have those lived experiences kind of ingrained themselves in a person's mind, right? Now, getting into some more kind of strategy here, I think it's always important when we're engaging in the risky work, which I really do think that it is. I think trauma reprocessing is risky work, especially if a person has dissociative characteristics, self-harm in the person's life. Um, and especially if there is addiction in the person's life, because all of those can be ways in which the person is hyper self-regulating, is what I can say, but the way that they're trying to numb out or avoid what they're feeling. So I think it's very important to, even if I know trauma reprocessing needs to happen, I need to think about when. When is it the time to actually start facilitating the recall of those traumatic memories? So there's an assessment work, and then we're going to get into some interventions as well. From an assessment standpoint, so many of us know kind of the process of some type of biopsychosocial intake, all the data gathering, but I really encourage the use of assessing a person's attachment style. Sometimes, for sure, people disagree with the result, or sometimes you can even just teach what more attachment-related avoidance looks like, attachment-related anxiety. People can kind of self-identify. I find that to be just a decent method as well. But regardless, some kind of way to give both you and the client some awareness and insight into the way in which they engage in relationships, because that can create implications for us in our therapeutic relationship, but it can also create implications for how they seek out support, following the trauma reprocessing session as well. And then I know sometimes people have such time crunches or a huge caseload where it's just very difficult to engage with family. But I think it's so helpful to actually ask family members when this person's going through a distressing event, how do they typically respond? Do they seek out support? And if they do, how does that normally go? So asking for some collateral information is very, very important. And then some of the preparatory work before the trauma reprocessing is actually identifying some attachment figures. We don't have to use that term. We can just say, who do you have in your support system and how do you engage with them? Do they feel safe? I know we wouldn't ask it in a closed-ended way, but some type of kind of open-ended way to find this information. And then really just identify what comes up. You know, you find yourself, you're like, okay, I need support. Um, I'm going to make a call, but then they answer, and then something comes up where you're not really authentic or able to express yourself. So identifying barriers there. Now, from that, we can shift into some interventions here. And let's get into some practical strategies that with every client, and I say that without exaggeration, with every client that I facilitate trauma reprocessing, I'm utilizing some of these practices right here. A lot of times before I actually engaging in any kind of trauma work. And in fact, the more impairment that I see that a person has in being able to seek out support and engage in support, um, the more I would say PTSD treatment is contraindicated until further notice. I need on my end, this is just kind of my own theoretical lens of I need to see healthier engagement with other people. And some people might say, well, but they actually need the trauma reprocessing before they can engage in that. But I want to go back to the words of Shapiro of saying the trauma work might not actually lend itself to healthier relational patterns. So when that's the case, maybe just finding other people for them to seek out support than maybe their family members or their romantic partner. Sometimes it means encouraging them to attend group counseling or a 12-step meeting. And a person does not have to be a quote unquote addict to go to 12-step meetings, in a sense, there's so many, even Emotions Anonymous can be very helpful with these matters. So there's so many ways to get support, but I do think we need to do some assessment first because they're leaving our session, and I think it's a bit on us as an ethical obligation to know they know who can provide them with support and they actually have the skill set to receive support, to ask for it and to receive it from other people. And that is establishing security on our end that it's the proper time for PTSD treatment. So one of my favorite interventions that I promote, it's not done in office. I ask the client, I describe what Thanos is, which is a weekly check-in. And then with permission, if I have assigned ROI, I talk to a family member like a romantic partner. I've even done this with the son and his father. Um, but actually really encourage some use of a weekly check-in. I don't care what format it is, but I just think Thanos is very helpful. Um, Thanos does have the background of being developed for um, a husband and wife, where the husband had a sex addiction and his wife wanted a check-in every week, which is very warranted. But I've adapted this, like I said, for a son and a father. So we can also find other formats. But I want something in place where a person has the ability on a more consistent and predictable basis to engage in a very vulnerable, meaningful way. And so that's what Thanos allows us to do, is it gives us a structure to have communication. So it starts with feelings, just sharing with your partner, a parent, a friend, if they're willing. What are you feeling? Affirming the person, acknowledging some type of appreciation. And it doesn't always have to be about that person. Maybe it's an affirmation about other people, maybe somebody at work. um, Identifying needs that you have, which to me is actually negating sometimes the negative self beliefs as well, which is very important. Ownership, that no, it's not your fault, and we're always contributing to the way our life is going. So there's a bit of that. And then struggles and sobriety. So if a person is working through an addiction, this would be the opportunity to talk about their sobriety. But plenty of people might just have some type of struggle related to some type of urges or overspending or eating in a way that's not within their value system or they feel powerless over it. But acknowledging some kind of struggle, this consistency and predictability is oftentimes starting to create safety in seeking out support, right? And so I think it's very important when we're teaching people how to receive support from other people and how to be vulnerable, that we make it as consistent and predictable as possible, which is why I like a client showing me, and I say showing, but really telling me that they're actually starting to use this with a partner every week. And then sometimes it's me checking in with the partner of how did that go for you? But some kind of way where this is establishing safety and bringing our distress, our discomfort to another person. Another aspect of this is getting at emotions. So much of what makes, trauma traumatic, in a sense, is the distress that we experience of what am I feeling in my body and what do I do with what I'm feeling in my body. But before I can even get there, I have to be able to kind of name what's going on. And so I find this work to be very important with people who have a lot of attachment related avoidance. Because if you think back, attachment related avoidance suggests they push down, they suppress or deactivate their emotions as a way to cope. Again, it doesn't mean they're not experiencing emotions and not being impacted by their environment, but it means that they cut off awareness of what they're experiencing, which means they're not able to get support from other people. So I think it's very important to actually, before trauma reprocessing work happens, to actually build out a client's emotional vocabulary, helping them to put a name to what they're experiencing in their body. And I'll kind of give you an example of this. And I think in an ideal upbringing, um, Kids, of course, don't come out of the womb here knowing what anxiety is, knowing what sadness is. But a lot of times they have the words to describe the sensation of such emotions. So, kind of stereotypical one of like anxiety feeling like butterflies or feeling like nausea in the stomach. So, a kid growing up might experience this kind of upset in their stomach and go to a parent and say like, "Oh, like my tummy hurts." And in hearing, "Oh, my tummy hurts," a pretty attuned caregiver maybe could recognize something in the environment is a little bit nerve-wracking. First day of school, first day of preschool, something like that. And then the parent is saying, "Oh, are you nervous right now?" And so immediately, like the kid is learning that there's a name for what he, she, they are experiencing in their body. It's like, oh my gosh, like this sensation in my stomach might mean, not always, but might mean I'm nervous. And then the other thing that's happening with the attunement in that moment from the caregiver is that, let's say dad. If dad is naming that, that's anxiety, and if dad can stay calm in that moment, it's actually demonstrating to the child, um, this is safe. This is safe to feel this emotion. It's not pleasant, but it's safe. And because it's safe, and I'm actually learning, wow, that was so helpful to tell dad what I was experiencing in my body. He helped me to name it, he helped me to understand it, he made me feel safe with it. And so, ideally, if we think back to that chart, it's actually wiring in that kid's brain that people are very helpful when I feel this way. I'm going to, moving forward, I'm going to talk about it, right? Because that was super helpful. Not everybody gets that growing up. Sometimes people are really left to their own to figure out what in the hell they're feeling in their body and what that is. And so sometimes it takes therapy. I mean, sometimes people, it can be decades into a person's life before they know what that thing is in their tummy or what that thing is in their chest, that heaviness, that emptiness. Sometimes it takes people in their 60s and 70s to put an understanding to what's going on within their body. And the more equipped they are to be able to name what's going on and to be able to seek out support for it, the more it kind of helps people to realize, um, wow, talking about it really does alleviate the distress with what I'm feeling, right? But I do think it takes some both experiential work and some psychoeducation for clients. Um, to be able to put a name to what's going on. And if you're doing trauma reprocessing work, it's so important that clients can name that invisible thing that's happening within their body. Because if you think about it, something that's so powerful is actually something that's invisible. We'll never be able to feel it, right? Now, I know I've put this chart in front of you, and you might say, what in the world is this about? But just to reference emotions, um, this was a study done. The participants are mainly from Asia and Europe. This is a composite of 700 people's answers where they were given a body silhouette, which is what you see, with an emotion word. And they were told on a computer they had a way to basically kind of color in the body silhouette where within the body they felt these emotions. And then the colors correspond with the intensity of what's being felt. So orange, yellow means you're feeling a lot of something in the body. So like happiness, anger, that really creates a sensation in the body. Whereas blue, kind of white, that's more of a lack of feeling in the body. And so I think a lot of people get relief, especially if you look at depression. Depression is more about a lack of feeling in the body. So what I've found is that people, yes, have their individual differences with where an emotion is experienced in the body. We can call that a somatic location. But just the point that, yes, our emotions are felt in our body, and we need to be able to drop down into our body to know what's going on. And it's oftentimes through interaction that people help me to make meaning of what's going on and establish safety in what I'm experiencing. So I think this is very foundational work for us before we start to initiate trauma reprocessing. Um, Sometimes people can spend up to 7 sessions just on establishing an emotional vocabulary, and along with the emotional vocabulary, just the words, actually developing awareness within the body of what it feels like within your body and where within your body. I know sometimes the clients that I work with, especially in a group setting, they kind of mock what I say of like, because so often when they're like, uh, they're saying maybe I'm sad today, they know what's coming from me is, and where do you feel that in the body? Because it's that connection that I'm trying to implement in a person's life of, yes, I'm aware I'm sad, and I know exactly where within my body I'm experiencing it and how it feels in my body. And that when people develop a language like that, it lends itself to interactions being much more helpful, where the other person can understand much more about what's going on, right? Okay. So building out some emotional vocabulary. This, I'm not going to quite go into the study, but I just want to say, from a nonverbal standpoint, for us to really feel felt understood by another person, it doesn't always have to be about the words. It doesn't always have to be about what's being said. The right side of our brain is much more sensitive and it processes how something is being said. So occasionally I'll get a client who just gets so hung up on how they're talked to, not really how, but what words are being used by the other person when they seek out support. And sometimes it's very legitimate, like the person can be very invalidating or problem solving, and I get it. But I really promote for the client, hey, I get that they try to problem solve all the time, but could you actually listen to how they're talking to you? Listen to their tone. Instead of being so focused on the what that they're saying, notice how they're saying it. And so often, if you kind of prompt that way of being in an interaction, even though, yes, there's kind of problem solving coming my way, I feel the care from my caregiver. I feel the care from my romantic partner. I don't really love what they're saying, but how they're saying it, that's so helpful. And so I encourage that kind of redirection um, with folks. Once again, especially once they leave a session and maybe they need to talk about or debrief about what their session was like with me as a therapist. Like they need to be able to talk about it. And so just focusing on not so much what's being said, but how can be very helpful. Unless, of course, it's very critical in nature, and that's another topic as well. But a lot of times just focusing on how can be that very helpful shift for a person. The other aspect of communication is, I prompt all the time, hey, talk to people about what you're feeling. And then so often in their demonstration, they respond with, I feel like, and if a person says, I feel like, they're not actually about to share their feelings, they're actually about to express their thoughts, which is not typically helpful in trauma reprocessing because that's how we're talking all the time. And it can be sometimes helpful, but what brings about healing is oftentimes us being vulnerable and authentic in our emotions. So, a lot of times when you say I feel like, you could basically just say I think. So I feel like you don't get me, right? Because we would never say I feel like happy. That's not how we talk, unless maybe there's some kind of dialect happening. But I feel like sad. I feel like happy. We don't know. If we say I feel like, we're about to express a judgment or a thought, which is probably not what the person asked, especially if you're being asked, hey, how are you? Like what's going on? They're like, well, I feel like going to the store, or I feel like not getting out of bed. Yeah, but tell me how you're feeling. Well, I feel sad. I feel discouraged. So that's different. So sometimes that little redirect right there of helping them to catch themselves if they say like, to direct them to actually drop down into their feelings, and then even using a feelings wheel. I Most of my clients are kind of up there in age. I'm not talking about people in their teens. I'm talking about people, middle age who it's so helpful to use a feelings wheel. Regardless of age, um, it's and when I say that, I mean I don't care how old you are, your IQ. Like literally, sometimes you need a feelings wheel in front of you to learn how to articulate what's going on, right? So the other study that I want to point out, we're starting to come to the end here with the interventions and closing it out. We'll wrap this all up. But the other aspect of this is helping a person to, once again, when they build out their emotional vocabulary, they can be more perceptive to how other people are feeling. So this study was using an fMRI, really focusing on the amygdala, which is the fear center of the brain. You know, when we feel threat, it's really activated. And they showed an image of an angry person in the fMRI machine, and they were trying different things out. Like what helps deactivate the amygdala the most efficiently? And so there were things like label the emotion. That person is sad. Affect match. Show us yourself with that emotion. What gender is this? You know, based off perception. Or if they ever give them multiple choice, match the gender of the person, or just look at it. What they found was when you can learn how to accurately perceive what another person is feeling, not that we aren't wrong, sometimes we are, but generally speaking, when we become more perceptive on how another person is feeling, it actually establishes safety within our own body. And so this was mainly about anger, but let's kind of generalize this in a sense of there's some potential here that the more I can realize what's going on with another person. Now, I'm not mind reading. I'm not trying to figure out why. That's when we get ourselves in trouble. I'm not trying to figure out why the person feels that way. But when I'm perceptive of how a person is feeling, I feel a bit of safety within my body, and that can lend itself to asking, inquiring with the other person. Hey, you kind of seem angry right now. Uh, am I off on that, or is there something going on? Um, that that is oftentimes what helps a person with that. So there's some interpersonal skill there. And once again, I know just because we're perceptive does not mean that the other person is going to appreciate that perception. And again, that's more work or different work. But I show this to clients pretty often and say, look, it's very important that you begin to learn kind of like cues from another person about what they're feeling so you can inquire with them about what's going on, right? That lends itself to very vulnerable communication. Okay. So going over all that, um, coming back to Thanos, which, like I said, I think is very helpful to set the scene for consistent and predictable communication, but then also have these impromptu moments where we need support as well. So you have these slides. Here's an example of Thanos as well, which I think is very helpful to encourage with clients to establish consistency in seeking out support, seeking the support and actually receiving the support and reciprocating that. You know, you providing support to other people. Okay. Right. The last thing that I want to say before we start wrapping this up is security priming. Once we have established some pretty positive lived experiences with people, now that might actually come from a person's past before we started working with them, or the work that we've encouraged, we actually really promote in session for them to recall those moments. So just kind of like trauma reprocessing has a person recall very adverse moments, security priming is in a sense the opposite. It's having them recall very meaningful moments um, with a person. And there's so much research. These are meta-analyses on here. So it's not just one study, but meta-analyses have really shown the tremendous benefit of facilitating security priming, which is, again, in different ways, but having them recall very positive experiences with other people. It's associated with decreased negative affect, increased, positive affect. It's been found to be beneficial for both people with attachment-related anxiety and attachment-related avoidance as well. So when we think about various attachment styles that are insecure in nature, I really want to promote doing this as preparatory work, teaching people how to recall very positive experiences with other people before we shift them into more traditional trauma reprocessing, which is the recall of very painful woundings in their life as well. Okay. And all of that is kind of just re-emphasizing here the case conceptualization, how we're gathering the information, some of the interventions that I facilitate, and then reassessing for their readiness for PTSD. Or maybe potentially we've integrated this throughout our PTSD treatment as well. So I'll close out with this, just a reminder of when I think about PTSD treatment from an attachment perspective, I'm thinking about um, prompting and promoting interpersonal work, actually promoting how people are engaging with people outside of session. And I'm thinking about the meaning making that a person does um, in their mind. Basically, what do they think about people? What do they think about themselves? And the beautiful work that can be done is, I don't know if you can see my mouse, but 3B, promoting these corrective emotional experiences, which really alter the way they see themselves and other people, which lends itself to healthier engagement with other people, especially when they need support. Right. So thank you all. And I believe we're at the end. There are
We
references
are.
and then questions right there.
Thank you, William. We do have a few questions, so I will start this. Y'all will go up till about the top of the hour. Danielle asks, in trauma work, have you experienced clients who engage and connect, and then later in a later session, maybe 2 or more weeks later, there is a disconnect? And as you gently bring awareness to this disconnect and give them space to reconnect if they wish, but then they are shocked they didn't realize it and start their self-condemning talk.
Oh gosh, yes, that is such a good question. And I think that that really embodies sometimes the patterns that people have had in their other relationships as well, where, relationships reveal us. They help us sometimes to get in touch with things that we don't really want to get in touch with. And sometimes, as much as we appreciate that connection in the moment, when we disconnect, it's like, oh my gosh, that was so scary to get in touch with that. And then we find this kind of pulling back in the relationship. And so there's a wonderful opportunity in trauma reprocessing for corrective emotional experiences to help a client to develop some awareness and insight into that, what I would call a relational pattern in that moment, and to promote a corrective emotional experience where they're not being condemned. And I will even say, and they're not being chased by us. Sometimes when people do that in romantic relationships, it creates this very unhealthy cycle of when I pull back in distance, somebody pursues me. And then that's the way in which I learn how to get any kind of support is I pull back rather than actually go forward and assertively and vulnerably ask for that support as well. I could probably answer that question for 20 minutes because that I think it has such implications, but that's where I'll keep that one. But I love that question. I
Okay,
think it's so relevant.
great. Right. Jed asks, would the notion of calling a pattern maladaptive be related to the environment that belief and behavior is being applied in? It would seem that people adapt to an environment in a way that protects them, but then get stuck in that attachment pattern and are rigidly or repetitively using it in other environments where it becomes counterproductive.
Yes. I'm not sure if that was a question because I would just say yes to what you said. Yeah, maladaptive in the sense of, I mean, you did what you knew to do to survive and to get through it. So I know sometimes things sound pathologizing of like we're calling something irrational or maladaptive, but from an attachment or even interpersonal context, I kind of bring up at one time in your life, you needed to do that thing. You needed to respond that way to survive or to get through it. The issue is you don't really need to use that skill anymore in the present day, and especially in this present relationship. But our brains get stuck. And well, historically, this is how I've kept myself safe. But that is then creating a huge disconnection between us and that new person. Right. So yes.
Next question is, I'm currently reading Facing Love Addiction by Pia Mellody, and she states that it takes 3 to 5 years for someone to recover. Is this the same for all insecure attachment styles?
Yes, and there's quite a bit of different research, but the top is 5. That is the most consistent um, results that I've seen is that attachment work can take up to 5 years. I've seen 2 to 5 years and I've seen 3 to 5 years. What I say to people is that all along the way, you're probably experiencing progress. Think about attachment-related anxiety and attachment-related avoidance. Both of them are a spectrum. It's not you either got it or you don't. It's a spectrum. And so over time and over experiences, you start to see both of those be lowered, which then promotes security in the relationship as well. So, yes, it is a lengthy process, which I think from an informed consent standpoint, um, we do discuss with clients as well. But that work doesn't only happen with us in therapy. That work really needs to be promoted outside of therapy and their other relationships as well. I didn't bring it up in here, but a study that I would really encourage people to look at is the ideal parent figure protocol by Dan Brown, not the one who wrote the Da Vinci Code, but Harvard professor Dan Brown. The ideal parent figure protocol looks at through guided imagery how to promote a more secure attachment style.
Fantastic. Next question. What about the client who is stuck in their belief in themselves as a victim and immersed there in a disassociative process? Think about the client who is triggered by therapist's words, could be empathy and goes towards their victim beliefs and hug them as a teddy bear, in quotes.
Hmm. Yeah, yeah. Well, dissociation can be, a very common characteristic of trauma. Once again, viewed on my end as a survival strategy. For me, dissociation could be conceptualized as a deactivating strategy, in that you're disconnecting from the overwhelm and pain from what you're feeling. So, I can answer this in different ways, and I might not be getting at what the person's asking for, but I do think an integrative approach of when a person does have strong dissociative characteristics, they're quickly shifting into a dorsal vagal state, if we think about polyvagal theory, and it can be very important to actually induce some energy in the body. And so I think very simple methods, not easy, oh, here's a quick fix, but simple methods of having a person literally sitting in a chair on a couch do like calf raises, like just while sitting, but kind of inducing some energy in the body, moving their hands, clenching their fist, and just really encouraging them uh, to kind of notice I'm with them in that moment. So as the energy is coming back in the room, they're also experiencing kind of my presence in a sense as well. And I don't think having people close their eyes is the most helpful when people have strong dissociative tendencies. I think it's important to have some level of visual contact with me, even if it's gazing off to the side or at the floor, kind of keep me in your peripheral so that you just feel that I'm with you in that moment as feeling begins to come back to the body.
Great. Next question. Does Thanos help the patient deal with the trauma instead of avoiding it?
I think it's lending itself to creating safety and talking about their feelings. Um, I do think that there's research that shows there are other ways to actually reduce post-traumatic stress. It is not the only way to actually have a person need to recall the memories. In fact, there's research that shows just teaching people how to talk about their emotions in general, which is why I promote Thanos, just in general, not about the trauma, about anything that's going on in their day at work. Teaching people how to talk about their feelings actually can lend itself to PTSD symptom reduction because you're establishing safety in relationship. So you're not avoiding as much. The fact that you're engaging with other people is probably helping to correct some alterations in cognitions, and it's helping our nervous system to kind of come down as well. So that's why Thanos, which might have nothing to do with your traumatic event, can actually help promote steps towards symptom reduction. And please don't, I did not just say Thanos has been researched to say it can lead to PTSD symptom reduction, but it's a practice that lends itself to skills that can be very, very helpful with PTSD symptom reduction.
Great. This attendee wants to know, speak to treatment resistance. I have a client that will not stop avoidance and will not grow supports.
Mhm. Yeah, that can be one of the hardest aspects of this is prompting people to actually engage with other people. My go-to with that is that they're probably engaging with family or friends where there's just history with them. And so I know some people are truly debilitated, even just kind of getting out of the house. But I really promote some type of community meetings. And like I said, I'm in the addiction world. And so I think people just encourage them to sit in a room. You don't have to talk. Just sit in a room and experience other people as well. I do know some people might encourage something online like a forum. I'm not really a fan of that in this context. I mean, I think it's healthier to just even just sit in a room with other people. Maybe you're not talking, but just feel the presence of other people. And I think that becomes a bit of exposure therapy of establishing safety and connection. And then from there, if I see some progress and at least just getting out and being with other people, then promoting an interaction with somebody as well. Just introduce yourself and then share how you're feeling. And then let's ask them out for coffee. But a stranger, sometimes that work can be easier, not easy, easier with a stranger than it is with family, friends, coworkers, things like that. But with my clients, I'm constantly prompting, spend time with people, go out with people. And yes, there are always some barriers there, but that becomes the work of how do we establish some safety in seeking support and even just recreationally hanging out with people as well. This is a bit gendered, but men especially just encouraging some type of activity as well. We're not talking about your feelings. Um, but an intramural sport or things like that. And I know other sex and genders that might be applicable as well, but I know especially with men, if it's more activity based, it can be a bit easier to engage.
Fantastic. We're going to take about three more questions here. Just to set up this one, Charlotte is speaking from in reference to EAP referrals. So those sometimes they only provide about 5 or 6 sessions.
Yeah.
Here's her question. How to work with managed care and number of sessions, especially as we do need to do the preparatory work before beginning the deeper work, is her
Yep.
question.
So a lot of this work, I'm yes, in session, I'm explaining why, but a lot of the work that I'm saying, I'm actually promoting to be done outside of session. So Thanos is not taking up my time in session, other than just talking through it, describing the importance of it. I could probably do that in 10 to 15 minutes, um, but I'm promoting a lot of exercises outside of session so that our time together is not really focused so much on that. I mean, 5 sessions is going to be a stretch for trauma reprocessing, unless the person just has support, knows how to engage in support. Um, Even like interpersonal psychotherapy recommends, gosh, I think it's 10 to 15 sessions for trauma reprocessing. So it's definitely a stretch, and I would hope that insurance would recognize the need for more sessions. As long as you're showing I'm using evidence-based treatments, here are the barriers, here's why I need more sessions. But to go back, a lot of these exercises are prompted to be done outside of session so that we're not spending our time together on that.
Great. Two more here. You mentioned DID. I'm working with an adult with this now. Can you give any suggestions for this population specifically?
Yeah. So I'll be careful on here. I have kind of my scope, I'm not highly experienced with dissociative identity disorder, but dissociation in general, which definitely being on a spectrum from sometimes daydreaming all the way up to um, meeting full criteria for DID. But along that spectrum, where people are do have a propensity in their overwhelm to disconnect in some way, maybe not so much mentally and from their personality, which is more characteristic of DID, but more so just disconnecting from the overwhelm and shutting down. This is where I really think it's very helpful to get people to really embody what they're feeling and stay connected. Again, probably there are people more qualified than I am to answer this question, but I don't think when people have strong dissociative tendencies, it's wise to prompt a lot of closed eye setups, sometimes with EMDR, sometimes with brain spotting. I think it's important for them to stay with their eyes open and at least prompt a soft gaze or just check in with the person as well. I do remember one person who had those characteristics very strongly. And anytime I accidentally, like when I really kind of realized what was going on, prompted her to close her eyes and to envision something, that's when the dissociation really activated as well. And so I learned through consultation, really, promote her to keep her eyes open. She can shift towards the floor, but just have her kind of check in and look at me as well, to feel that connection. Because going back from an attachment theory perspective, connection helps regulate as well. I know sometimes we might say the opposite, but close systematic progress and felt connection establishing safety.
Great. Last question here. When a client has been let down by people in the past, finds it hard to do the support groups and accept support because everyone will let them down, how would you deal with this?
Mm-hmm. Um, so that chart that I showed you, I show my clients that chart, and one of my favorite exercises is to actually have them, not favorite as in I enjoy it, but I think it's very meaningful, of have them really validate, like in the past when you sought out support, um, what happened? What went wrong? How was it? How were you misattuned? How were you really let down? And but then it's like, okay, now you're in a present day relationship where you're really not even giving the person a chance to be different, which is the avoidance piece right there. And so sometimes just helping a client to realize how they're projecting their past experiences on a current or present day relationship is sometimes the awareness a person needs to give the person a chance. And then, even with giving them a chance, it's very important to bring in the concepts of all good or all bad, which is object relations refer to that as splitting. And then, if anyone's familiar with, of course, borderline personality disorder would refer to that as idealization and devaluation, like all good and all bad. And so that's that work that's very important of, hey, people have let you down. You have a propensity to go towards they're all bad now, rather than learning how to integrate the good and the bad of every relationship, which is actually part of us being human, right? There's good and there's bad. So that's the meaning making work that I would do in that moment. You're going to be let down. How can you appraise that in that moment? And ideally, they learn to say, yeah, people are humans. They let me down. That hurt. I validate my hurt. And I'm going to keep engaging in that relationship, given that it's not abusive, but I'm going to keep engaging in that relationship.
Fantastic. Thank you so much, William. Everybody, thank you so much for joining us. We really appreciate it. Just a couple housekeeping items again, reminders. When you end this webinar, there will be a link to click on the survey. Please do fill that out. We will send the PowerPoint presentation, the recording of this, as well as your certificates next week. Please look out for them on July 23rd, Wednesday of next week. Thank you all. Have a fabulous day. Great rest of your week. We'll see you soon. Bye-bye.